Okay, guys, welcome to our live webcast, Billing and Compliance and Pain Medicine. Thank you for joining us. My name is Dr. Matthew Maroney. I'm a assistant professor at University of Florida in the Anesthesiology and Pain Medicine Department. I will be serving as a speaker and the moderator for this webinar. We are also joined by our other speakers, Drs. Windrick Lynch, Kevin Vornkamp, and Miss Stephanie Young. So Dr. Windrick Lynch is a pain medicine specialist at Tallahassee Neurologic Clinic. Dr. Kevin Vornkamp is the chief of the Pain Medicine Division, associate director of patient safety and quality improvement, and associate professor of the Department of Anesthesiology at Duke University. And Ms. Stephanie Young is the director of the professional fees at the University of Maryland. So specifically, I want to point out that at the bottom of your screen, you'll notice a Q&A icon where you can submit questions to our panelists. All questions will be that you submit will be addressed by the presenters in the order which they are received at the end of the presentation, depending on the amount of time we have. All right. So I'll start off by just touching base on the concepts of hospital versus ASC versus in-office coding and billing and charges. So I have no disclosures. So from a basic standpoint, I think there's three environments you want to be aware of. There's the in-office, or just kind of what you think it's just at doing a procedure with fluoro in a clinic, not in a surgical center or a hospital. When charging, you're going to really consider the fact that you get a professional fee and probably some money for your supplies. That's much different than the ASC or ambulatory surgical center setting, where you'll still get a smaller professional fee, but there's a facility fee that goes towards whoever owns and invests in the ASC. And then they compare that to the hospital setting, where you get the same small professional fee, but an even a larger facility fee. So this is the website, just as an example, that we use at UF to look up reimbursement, specifically Medicare. I want to point out with the big yellow arrow that you have to actually look up a Part B. Part A is something else. So you could go on there. It's a free website. You look at on the left-hand side fee schedules. You find fee schedules, and you'll see this screen. And if you type in the CPT code, which I have 64493, that's for the medial branch block. And you have to put your locality, which you can look up. That's based off of your geographic location. For example, at Florida, there's 3 localities that's based off of population density. So we are in locality 99, so you can look it up easily. In this example, you can see specifically that these you see non-fac par. That means that stands for non-facility participating. So if you're in a non-facility, you're in office, and in this setting with this CPT code, you're going to make $174 for your one joint MBB. If you're in facility at an ASC, that drops to $91, so it's nearly half. There we go. If you don't take that insurance, like you don't take Medicare, that's the non-fac, non-par, so non-facility, non-participating, you get paid a little bit less if you don't have a agreed upon contract with Medicare for this example. So you can further look at what the facility fee is for the ASC. So if you look at amount, it goes $412.28. So it's kind of a pretty substantial amount, at least double your fee. And if you use a different website, you can find the hospital fee, which that's almost $1,100. So you can see that the amount reimbursed can really vary based off the professional fee and the facility fee. I think it's important to really understand why this even exists. So before Medicare, before all this system was created, historically, physicians just charged whatever whatever price they kind of charge for each patient. Frequently, they would charge the wealthy much more, and they would have a reduced or waived fee for the poor. And this caused a lot of variability with fees, and was arguably a disorganized system. So the Medicare RVU system was created to kind of regulate this, to have a standard fee that Medicare would pay for the elderly, and or Medicaid would be for the poor, and so that there was a kind of set system in those settings. So other systems pay you in the RVU system. So RVU is a relative value unit that's comprised of your physician fee, practice expense. So it might be your radio frequency, needles, ablations, tools, and you get malpractice expense. And this can vary based off of your geography. Obviously, Hollywood's probably going to be charged a bit more than some middle of nowhere in Idaho. And using that same website, you can look up your RVU. So specifically for one level MBB or one level joint, so 2 MBBs realistically, your RVU would be 1.52. And depending in your work setting, like I know somebody that gets $60 per RVU, which I think is really good. It could be substantially less than that, maybe potentially more. So just to keep going with this example, a second joint, CPT code 64494. So the professional fee in office drops from 174 to 90. That's in office for the second one. So the next joint is less. And ASC, it drops from 91 to 52. So that's less as well. Bilateral procedures. So you may think that if you're doing twice the work, you get paid twice as much, but that's not generally the case. Usually you get 150%. So if you get $100 for one-sided ablation, MBB, whatever it may be, you get 50% more, or 100. So if you get $100 for one-sided, you'll get $150 for bilateral in general. Just to complete this example, I think it's important to point out that you get paid per joint you work on, so it has to be the entire joint. So if you do one MBB, you will not cover any full joints, and you will make no revenue. You have to have at least 2 adjacent MBBs to treat a full joint. If you want to do 2 joints, that will be 3 adjacent. If they're non-adjacent, that's going to be 4 MBBs for the 3 adjacent or 4 non-adjacent would get paid the same amount. Generally in this scenario, there is a maximum of how much you can do. Generally it's 2 joints bilaterally. So that's kind of why we'll do, L4551 bilaterally in the lumbar spine. My understanding is that you can appeal for more coverage in an abnormal situation, like the patient has severe scoliosis, a compression fracture, you want to treat more joints. You can appeal for that, and which requires a lot of work and may not be approved. So at our facility, we very rarely do that. This is an example of Medicare A and B. So private insurance is going to be generally substantially more, on average, about 30% more than Medicare. On the other direction, Medicaid is 30% less than Medicare. So that's nearly, on average, you're getting paid half as much as private insurance, which is why there are some locations that may not, accept that. I wanted to point out how much this can really vary, because that one example, in office versus ASC, your professional fee was, half. It is not always the case. So in a SES trial, so CPT 63650, your in-office physician fee is over $2,200. So pretty substantial, and that drops by 70-80% in the facility. So $2,200 drops to $420 if you're in the facility. And my understanding is that Medicare, Medicaid, all these things are kind of evolving to try to decrease costs. One of the ways they're doing that is that they're making in-office reimbursement more lucrative, to try to promote people to, not surprisingly, cut costs where they can. In other words, not pursue these things in the hospital if it's not necessary, and they reward the physician to some degree by increasing their professional fees so that it can make sense. So I think that where this kind of comes into play to some degree, not that this is a simple subject, but If you're starting your own practice and you don't have access to an ASC and you can't invest in it, then maybe it makes sense to maximize your in-office setting procedures. And that's the argument that if you're providing a volume of patients to an ASC or hospital, that's the argument that you should consider trying to invest in it so that you can benefit from the revenue that you bring them. Because if you are bringing all your patients to an ASC and they won't let you invest in it, then you're really denying yourself, I would say, a significant portion of the revenue you bring, and it's just benefiting someone else. So I remember when I was interviewing, the people that had the ASCs frequently, like depending on who they were, if they were bigwig, they would pretty, confidently just say, don't even ask me to invest in my ASC. And I understand why that is, because they built it. But at the same time, I don't think it's completely fair to say that you weren't contributing to the ASC if you're bringing in patients. So it's kind of a complicated setting. It's not like you can just demand things and get what you want, but you do have a case to argue that if you're not going to be able to go in that direction, invest in that direction, then it just makes sense to not bring your patients there either. Done. I know that we're mainly going to do questions towards the end, but I have time for one. Oh, actually, that wasn't a question. Thank you, Dr. Hoornkamp, to specify what office reimbursement includes. So,
I have a question.
Okay, go ahead.
So, I'm not sure. I do all my procedures in a surgery center, but I guess a lot of that expense is all taking out of your own personal physician fee, correct? So you have to, yes, it's more of a physician fee, but then that's not counting all of the equipment, medications, staffing, overhead that you have to pay. Then you have to subtract that number. Am I correct?
Who's speaking right now, just so I know who I'm.
So it's Dr. Lynch. And
oh, okay, hey, Dr. Lynch.
That's what one of our arguments with the surgery center is, that all of the expenses get paid for by the surgery center. So we don't have to worry about any of that. Yes, there are some scenarios where it makes more sense to do them in office. But there are possibly some scenarios where the expense of a procedure might outweigh the reimbursement.
Yeah, I mean, you have a lot of experience in that direct. I have kind of an academic experience, so I've just been taught the basics about this, which I think my understanding is that every procedure, there may or may not be a substantial component that reimburses you for supplies. So based off of those numbers, it may not make sense in a sense. I don't think that they're all appropriately based the amount of supplies you use. So I would agree that I think depending on the scenario, I would look at each procedure specifically, individually, to determine what makes sense in your practice. It's my understanding. So I would agree. Go ahead.
I was just going to add that, it's nice to have the spinal cord stimulator cost, be really high, but that you have to realize that also includes the cost of the leads that you have to subtract, and depending on your contract with the spinal cord stimulator company may not be very good, or it might be really good depending on your relationship with them. So that'll take out a huge chunk from that profit.
Yeah, absolutely. And I think that's a good segue into Dr. Lynch's presentation, who's next, working on compliance basics, mid-level supervision, coding requirements, and pre-authorization.
Great. I'm just here, just trying to share my screen. All right, can you guys see that?
Yes, we can see the presenter view. It's not maximized, but
okay,
you can definitely see it though.
I'm pretty sure it's this one, but that's the presenter view. All right.
I mean, we can't read it.
Oh,
There you
there
go.
we go. Well, can you see that?
Yes.
All right. Well, I'll put that up. Okay, well, I just put that at the bottom. All right, great. Well, I'm Dr. Wendrick Lynch. I'm a pain management physician in Tallahassee Neurological Clinic. I'm private practice. I've been here approximately 6 years. I'm a partner in my practice, and I've also invested in our surgery center there. We don't do in-office procedure, although that was a really interesting talk that you gave. It made me want to consider having the option of doing both. Having some procedures done in the surgery center and some in office, where you can really just crunch the math and see where it would benefit one or the other. I know, ironically, the procedures that you may benefit more from in-office procedures are actually like bigger procedures, like kyphoplasty, spinal cord stimulator trials, which should, in my mind, be done in surgery center and not necessarily in office. But I digress. But we're going to be talking about incident 2 and mid-level supervision. So I had a really broad several topics to discuss, and there's no way to cover it all in 15 minutes. But so incident 2 is something that I think you'll depend. It doesn't matter if you're an academic, private practice, wherever, you're gonna need to learn this topic pretty well. It basically involves your role as a attending physician supervising mid-levels, nurse practitioners, and PAs. You might not have one right off the bat when you graduate fellowship or join a practice. You'll likely have to build up to justifying obtaining the cost of a mid-level provider, but in a way that can definitely allow you to leverage yourself into allowing your more time outside the clinic and being able to do more procedures. For example, I have personally 2 mid-levels working underneath me, and it took a long time to train them, but they are excellent at what they do. And they're just basically an extension of your practice. But incident 2 is a Medicare term that is a billing term. So what it means is you will be able to charge 100% of physician fees for the nurse practitioner or PA as if you were conducting the visit yourself. So disclaimer, I am not an attorney. I'm a physician. So what we're talking when we talk about incident 2 billing, it's just the tip of the iceberg. There's, if you want to look at all the rules, from the Medicare website, you can access them. It's several pages of just dense legalese terms. So, be sure to hire and consult legal experts and compliance experts so you don't get yourself in hot water. So in short, they define it an NPP, a non-physician practitioner. In pain management, that's a nurse practitioner or a PA. In other specialties, it can be a psychologist or a midwife or something like that. But from our pain management standpoint, it's a nurse practitioner or PA. If you're not billing incident 2, basically the nurse practitioner will go see a patient, and then if it's not under the direct supervision of a physician, then you can only bill 85% of the physician fee schedule. However, if the MD or DO sees the patient, or the nurse practitioner sees the patient under the direct supervision of a physician, then you can bill incident 2, which is pays for the 100% of the physician fee schedule. So that's why it's important. You're seeing many patients every single day. You want to be able to capture 100% of the fee schedule and not lose 15%. You're leaving a lot of money on the table, but there's requirements that you have to follow, and you have to meet all the requirements in order to bill as if the physician is personally performing the service. So again, this is the same slide. You're basically billing as if the physician is doing it. So if a nurse practitioner goes in, sees the patient, does trigger point injections, and you're able to meet all the requirements of incident 2, then it's as if the physician did it, performed the visit, performed the procedure, and you can bill 100% of the physician fee schedule. But if you don't, then you can only bill 85%. So here are the requirements at the Medicare Benefit Policy Manual. It's Chapter 15, Section 60. It doesn't apply to other things like lab tests, x-rays. It only applies to Medicare, and also in a non-institutional setting. So not in a hospital and not in a skilled nursing facility. So really, really does apply a lot to our field. So what are the requirements? There's lots of them, and there's several slides on this. So incident 2 services cannot be rendered on the patient's first visit or if a change to the plan occurs. So when I see a new patient, I physically see all the new patients when they come in. It cannot be delegated to a nurse practitioner. The nurse practitioner can see them and, initiate, the history and then come present to you, but then the physician must step in, conduct his own focus history, conduct his own physical exam, conduct his own evaluation and treatment plan in order to bill for future visits incident 2. So the Medicare credentialed physician must initiate the patient's care. And then if they have a new or worsened complaint in the future, so let's say it's an established patient and they have a new complaint or a worsening complaint, then the physician must again step in and conduct an initial evaluation management service for that patient. Subsequent to that initial encounter, where the physician establishes diagnosis and initiates a plan of care, then on subsequent visit, a non-physician provider, NP or PA, may provide follow-up care under the direct supervision of the physician. I highlighted and bolded direct supervision because now we have to define that. And then you define it by, in an office setting, it means that physician must be present in the office suite and immediately available to furnish assistance and direction throughout the performance of the visit or the procedure. However, it does not mean that the physician has to be present in the room. So for me, I'm off seeing other patients in clinic, or I'm documenting, or I'm, doing other things, but I'm present in that office setting when my nurse practitioner is seeing other patients. General supervision, which is a different term, means the procedure is furnished under the physician's overall recommendation and direction, but the physician is not actually present in the office setting. So this actually does not qualify for incident 2. So in our practice, when I leave the office setting and go to the surgery center to perform my procedures, I cannot bill for incident 2 because I'm not physically present in the office setting. However, any physician member of your group may be present in the office to supervise. So I have another pain management physician partner, Dr. Furmeister. And so we basically take turns going to clinic and doing procedures in a surgery center. So the days that I'm doing away from the office, my partner, Dr. Furmeister, he's in clinic and he's able to supervise direct supervision of my nurse practitioners. So it does not have to be the physician who performed the initial patient evaluation. It can be another physician member of the group. And the physician must, quote, actively participate in and manage the patient's course of treatment. And that definition can vary depending, on my understanding is it can vary from the different state rules. So you'll have to see what that exactly is defined as to actively participate. This is just more requirements. They may or may not be super relevant. Let's see. Yeah, so exclusions, the patient's first initial visit or with a new or worsening condition cannot bill incident 2. So consequences, you just like with anything else, following the rules, following the law, if you don't do it, if you cut corners, or if you blatantly choose not to follow the requirements, but still bill incident 2, it can lead to denied claims, non-reimbursement, setting yourself for audit. And if you're found at fault, you can be responsible for repaying all the things, all the charges that you billed, plus hefty fines. And if you did it knowingly and willfully, you can be found for fraud, and that could lead to a lot of other problems. So whatever it is, whether it's billing incident 2 or anything else, just make sure you're following all the rules. And the other thing I wanted to point out from the very beginning is that these rules can change from year to year. They can change regionally from, these are Medicare, so it's national, but you might have more local rules. So you want to make sure you have a good relationship, either in-house with a good billing and compliance expert who's up to date on the rules. They change every year, so make sure you stay up to date. So let's talk 3 scenarios, and then I'll be done. So scenario number 1, a nurse practitioner sees a new patient, steps out, presents to the attending physician. They discuss the plan with the nurse practitioner discusses the plan with the patient. The physician does not personally enter the room. Can this bill be billed as incident 2? And the answer is no. Because the physician has to, on the initial visit or with any new complaint or worsening complaint, has to physically conduct the evaluation and management visit. Scenario number 2, this is an existing or established patient. The PA examines and evaluates the patient, who then calls a physician at the surgery center offsite who's performing procedures to discuss a treatment plan. Can this bill be billed as incident 2? Also, the answer is no. Remember, the definition of direct supervision is that the physician has to be physically in the office setting and readily available to intervene if needed. Scenario number 3, the physician assistant performs trigger point injections on my previously established patient, but I'm hiking Mount Kilimanjaro, so I am not there. But my physician partner is in the office, but he does not step in during any point in the procedure. Can this be billed as incident 2? And the answer is yes. So as long as the physician is readily available to step in and in the office, it can be my partner, as long as it's another physician in the group. And you technically don't have to enter and be present during the medical procedure. So they can conduct knee injections, trigger point injections, Toradol injections without the physician intervening or supervising. As long as they're present in the room, you can then build that 100% with a physician fee schedule. If not, if me and no one's present, that's still fine. That the nurse practitioner or PA can still conduct the visit. Sometimes you'll have scenarios where docs call in sick or whatever the reason. There's no physician present. That's fine. You just bill 85%. So you don't bill incident 2. It's not as much money coming in, but still legal and still, allowed. Any questions?
Thank you for that, Dr. Lynch. If nobody has questions quite this second, then we'll progress to the next presenter. That will be Miss Stephanie Young with the title Assessing Your Practice, Billing, Collections, RVUs, Expenses, and Monthly Financial Reports.
Right, thank you.
Good evening, everyone. My name is Stephanie Young. I'm with University of Maryland Faculty Physicians Incorporated. Just a little bit about myself. I've been in the revenue cycle between facilities, hospitals, physicians, multi-specialty, and then I worked for anesthesia in the Baltimore area, 2 of the major health systems. So I've been in the anesthesia pain practice world for around 12 years. My background is health policy administration, compliance billing, revenue cycle, kind of the beginning from credentialing the whole way through the revenue cycle, the collection, coding, you name it. So I want to try to give an idea from my perspective from a business and really assessing your practice, looking at the key things that are coming into play as you're looking at billing, collections, work RVUs, expenses, looking at your staff in your office, how you staff yourself and what it costs to staff yourself and running your office if you're in a facility versus an office setting, and then monthly financials. And appreciate your time. So a couple of topics I'm going to talk about within is I'm going to kind of call what I'm calling the circle of revenue cycle in practice. That the pieces that are within the presentation, they're very connected. I want to talk about resources, use of data, knowledge, and willingness to change and make adjustments as you look at your practice. So the first is really looking at what I'm calling the circle of revenue cycle in practice, starting at the right-hand side. And these obviously can go left or right, because as you make a change in your billing, or you make a change in your collections, or you make something within your work practices that impact your RVUs or your expenses, obviously things are very connected in our world. So as you go left to right, the pieces change as you make changes, such as in billing. You're looking at what type of procedures you're doing, where you're working, what type of, who's doing your coding, looking at all the pieces that are coming into play. Is there in your marketplace? Who is your Medicare intermediary? What is your state Medicaid programs? What commercial payers are you participating or not participating? That can change, that can impact your billing, that can impact your collections. From a compliance perspective, most of us start at the Medicare level and look at the national coding rules and look at how we're going to get, we standardly try to code, but then you could have at a payer level, something that you do at a billing standardly, but then when you get to the collection level, you maybe get reimbursed. When you come around to your work RVUs, work RVUs is really a factor of compensation for physician productivity. So if you're working in, like for example, in the first presentation, there was discussion about if you're working in an office setting versus a facility, there's a difference in reimbursement. It can make a decision, for example, if you make a decision, maybe you want to do your trigger points in your office setting because it's more productive. It's more productive for you. You get better reimbursement. Maybe you get better reimbursement doing that in the ASC setting or in a hospital setting, depending on the type of procedure. And then obviously, the other next piece is your expenses. What does it cost to run your practice? What does it cost to do the services, depending on where you're doing those at? And then obviously looking at your staff, or do you have an outside company? Do you have internal? What does it cost you to do business? What is your administrative expense between your coding, your compliance? Do you do your own coding? Do you pay a certified coder? What kind of reference tools? And then looking at monthly financial reports, looking at what happened in the last month, what kind of patients you took, and really understanding your business. I think for us, that is a huge piece of that I find every day. I need to always assess what happened last month by looking at things like metrics and so forth. One of the items that I marked on my agenda that I wanted to talk about was data and reports. Data is very powerful, but also it can be dangerous if you don't look at it the right way. and use it in the right way. You know, and what result are you trying to get? You know, we typically in my organization, we look at monthly, we look at how we're doing operationally. We have budgets. Most companies do, you know, budgets, how you're doing against your budgets, how you compare against prior years. Was there something that changed in your business? Were there payers rules that changed? You know, we're in a new calendar year. A lot of us run on fiscal year, some of us run on calendar year, but payers, most of the payers in the fee schedules run on calendar year. And, you know, did a payer put a new rule change? Did they put a new local coverage determination that impacted billing, collection, and so forth? Resources. I've mentioned that a couple different times. You know, knowing your resources. One resource is your people. You know, who is doing your coding? Is it you? Do you have an office manager? Do you have an outside company? You know, reference tools. Different individuals referenced, you know, using your local intermediary sites to pull fee schedules, you know, payer websites, national coding rules. Medicare chapter 15 was referenced. Chapter 12 is big in physician. 15 is another, you know, using your reference tools and really knowing that these pieces are very interconnected. And if you make an adjustment in one, it potentially could change something and you might not know right away. You know, payers don't pay you as soon as you bill. There is inherent things in play with that. And then the last two items on my one is knowledge, understanding, and asking questions. Being able to ask the questions, even if they're not maybe something that is easy to ask, wanting to understand, and then obviously making adjustments. You know, if you're seeing in your, you know, there's a change, being willing to adjust to that and know it might not be easy to change, you know, and adjust to that. I think I've learned this over the years. Our market is always changing. If you think you know the rules today, they're going to be different next year. Or for example, like one of the big changes that seems to be really heavily on the regulatory is facet blocks. You know, facets are really being looked at, you know, and they made a change back in 21. Then some of us had some money taken back because they changed the way they were going to pay for it. They are now, you know, it's on the OIG work plan. I think it's keeping yourself informed and then making sure you're staying in the right lane. You know, I'm a big proponent of, you know, you got to adjust and change, and be knowledgeable and ask the questions. And you know, making sure you got the right people around you to help you do the best. And know that, you know, it is not easy in our world today, and everyone's trying to have you get paid less and less for what you do, for all the hard work you do. You know, from my perspective, my responsibility is to maximize reimbursement. And I will tell you, it is hard to do that today. The payers like to deny. They like to give you bogus rejections. They like to give you correspondence asking for documentation. You know, doing the things to make it easier as a practice. And I think it's, you always have to look at what's going on and adjust and change, and know that what you think today, it'll probably be different tomorrow. And you know, it's just a continual changing world. That was my biggest, my presentation was, you know, just knowing the pieces and using the tools and asking questions, and leveraging data, leveraging reports. And if you don't get them, ask for them. It's available. Somebody will get you what you need to do your job. Thank you.
Thank you, Ms. Young. Appreciate that. So our next presenter is Dr. Kevin Vorenkamp, who's going to discuss 2023 CPT coding updates and common coding errors.
All right. Are you able to see my slides?
We can see them, but it's not the presenter mode yet. We can see kind of the editing buttons as well.
How about now?
I think that's better. We can still see a little bit on top. We can see it. That's the presenter mode.
Oh, all right. Well, I'm going to go with this unless it's too bothersome.
I can read. I can fine.
Okay, so I'm going to talk to you about coding. And so what we'll talk about is the actual CPT coding. What I won't go into, although we can in the questions, is medical necessity and kind of what is required to do the coding based on either Medicare guidelines or the private insurer guidelines. So I'll review, I'll review some of the things over the last 4 years that are relevant to both pain as well as anesthesia. So this year, there wasn't a whole lot new. There were a couple category 3 codes that I didn't list here for transcutaneous magnetic nerve stimulation and a couple other things. But the big thing was this year, we had bundling of several of these codes into bundling of the imaging guidance, namely ultrasound, into several of our regional anesthesia block codes. And then there were further revisions with regards to the facet joint blocks. This is all in the CPT book for the changes that occurred. And whether imaging guidance is included or not. So imaging guidance as of January is now included with brachial plexus blocks, both single shot and catheters with an axillary nerve block, which this is actually being miscoded, which is why that got flagged. It's actually a pretty uncommon procedure where you're blocking the axillary nerve, but a lot of anesthesiologists are billing this code for brachial plexus blocks done in the axilla, what we call axillary blocks. And then the sciatic and femoral nerve, both single shot and catheter. Previously, since they were introduced, both the TAP and rectus sheath codes, CPT 64486 to 9, as well as the paravertebral block codes were already had the imaging guidance included. So what that means, CPT is kind of the first step in a process. CPT describes the codes, the procedures that are performed, and then it goes through the RUC valuation process, and then CMS issues a value for it, and then the private insurers do as well. But how the RUC math works is prior to this January, if you did a brachial plexus single shot, so a interscaling block with ultrasound, you would get that would be 2.15. I think that's right, 2.05 maybe work RVUs for that. The RUC recommended we get 1.5, and CMS initially proposed 1.35. In their proposed rule, and then ultimately went up to 1.5. And that's kind of the trend throughout these. Similar kind of these actually were unchanged, so no changes there. Actually, the reason I have this here, the change that occurred, I believe it was last year, was for the 2 years ago, and we'll hit this in more detail. Intercostal nerve blocks, the first level, slight reduction in the overall work RVU. How it was described previously as for the second level, it was 2 or more additional levels, and they switched that to each additional level. So there was, if you do 3 levels, you get 1.08 for the primary level and then 0.5 for each additional level. So kind of a change there. Similar in terms of valuation. I don't think we need to spend much time on this, but the trend is down. And so that's a lot of times we're approached by members or get comments from members saying we need a new code for all the new procedures that are popping up and being described. And certainly if it's a procedure that can't be described otherwise, and it's a procedure with strong evidence, then it does make sense to move forward. But when you add that new code, typically the existing codes, many times, certainly if it's been more than 3 or 5 years, also get surveyed, and typically the valuation is low. So you may add one code at a reduced value, and you may also decrease the valuation of all those other codes. I'll talk about this in a subsequent slide, but the SI joint lateral branch block codes in RF and the genicular nerve block codes in RF that came out, I believe, in 2020. And then I just included these in here because these, when we proposed these codes and when they were accepted, certainly 10 years ago, it was already to do these procedures, ultrasound was used more than 50% of the time. So when we wrote those codes, we wrote it with inclusion of imaging guidance. One thing you don't want to do is be creative with your coding. So if there's a procedure you're doing that's similar to an existing code, you should not use that. So a rector spinae block are similar to the paravertebral, but they are different. It's a different procedure. So you should not use the paravertebral block code. And you'll hear different from either different industry representatives or even at some of our society meetings. So just be very careful with that. If you're doing a procedure that is not specifically described in CPT, do not use close approximation CPT. There's either for peripheral nerves, there's the 64450, other peripheral nerve block, or if it's more of a plain block or other procedure, you can use the other unlisted injection code. And so that's the case for fascia iliaca, even though we know it blocks the femoral nerve, it is not a direct procedure. And there's language for many of these in CPT Assistant that from AMA that clearly defines that you should not use existing code, other codes. I'm going to shift gears, and I think this has already been touched on twice by both Matt in more recently, but the paravertebral spinal nerves have been looked at and of high interest for 10 to 15 years. The coding for this has not changed in the last 15 years. I think it was around 2006 for the ablation codes where you went from coding per vertebral level to coding for joint. So what I'm showing in the picture here, this is 2 vertebral levels, 1 joint. So you would code 1 level. Initially, if we go back to, I think 2003, 2004, for the block, you would code per joint. So this would be 1 level. Originally, for the ablation, you would code per vertebral level. But again, that changed over 15 years ago. But when they look at claims analyses for the facet joint codes, the most common number of codes billed for the last 10 plus years has been 3. The second most common is 4. The third most common is 2. And the fourth most common is 1. So the most common is people indicating they're doing this at 4 levels. And that's unilateral at 4 levels. So either people are coding inaccurately or they're not really doing the procedure in accordance with society guidelines. So I'm going to go through this a little more quickly. Again, this is all in CPT, but what they did for this year is there's a table that shows us all, but they went through a number of different scenarios. But this is, again, a reiteration of what's been the case for over 15 years. When determining a level, count the number of facet joints injected, not the number of nerves injection. So if you do bilateral L4 and L5 vertebral levels, that would be a single level code with a bilateral modifier. For that primary level, so again, if we're doing code with the 50 modifier ago is if you do a second facet joint for the add-on codes, either for the, sorry if my internet's going in and out, for the additional level codes, you can no longer use the modifier 50 in 2021. So for the subsequent levels, I would do the primary code with the modifier 50 for bilateral. And then for the second level bilateral, I would bill a quantity 2 rather than the bilateral modifier. And this table kind of goes through all of that for both cervical, thoracic, lumbar. Again, this is in the CPT 23 report at in the subsequent level codes. Again, it shows it in the table I showed, but the T12L1 level, do we code that as for the lumbosacral in the there has been guidance to both T12 and L1 as well as L1. And then for the code for that, you would do the add-on code. So again, a lot of this is going through somewhat unusual scenarios, but it's very well defined now in there. And
Dr. Vorkamp, if you turn off your video, it might be a little bit smoother. We'll still see your presentation.
Okay. Let me try to minimize.
But if you just stop your video, I think we'd still be able to see your shared screen.
Yeah, hold on. I'm gonna end my show and then I'll come back. I'm using a monitor, so let me just make sure. Yeah. Just see my slides now, or
Yeah, well, actually, we can see. Yeah, we can see them now.
okay. Is the Wi-Fi better or no?
I believe so.
Okay. All right. I'll keep my video off for now though. So yeah, the overall trend is downward. So this was actually identified by a work neutrality review. So CMS is required by Congress, by law, to maintain a work neutrality. They often do this by adjusting work RVU. If that doesn't achieve it, they also have the conversion factor that affects that. But yeah, the overall trend for the primary codes is down. And I think I've hit on this pretty hard, but for the primary level code, again, we continue to use, if it's bilateral, the modifier 50 for bilateral procedures. For the add-on codes, whether this is for facets or transforaminals, you do not use the modifier 50, but just bill it as a quantity of 2. Again, for the facets, so this has been a part of my talk every year for 12 to 15 years, and I think it's continuing to be coded inappropriately, or everyone's just doing 4 vertebral levels on every patient. But again, for both the facet blocks and RFA, we're doing it per joint. So for the primary level, 2 nerves. And then individually for each subsequent. So again, RFA of bilateral L3-4 medial branch nerves, the L4-5 facet joint. We're going to do the 64635. So this is the RFA. So destruction code with the modifier 50. If I add in the L3 vertebral level, the L2 medial branch nerve, I will now build that subsequent level code, the 64636, but not with the 50 modifier, but for quantity of 2. Other changes last year, there were changes with anesthesia for image guided spinal procedures. There was kind of a rewriting of those codes for if you're doing anesthesia for either spine injections or spine surgery. So there's some changes there. There was the introduction of the new codes for the intraosseous basivertebral nerve procedures. Those are pretty self-explanatory. And then there was the deletion of the epidurography code. This code, again, continued to be used inappropriately. A lot of people were billing it in addition to standard interlaminar or even transforaminal epidural injections. From many societies, both anesthesia, pain, and radiology societies, there was annual guidance and education to members for over a decade, and this continued. So the ultimate decision from the multiple societies was just to remove this code. Somatic nerve injection changes. There were, for similar reasons, for inappropriate reporting of several of these codes, facial nerve, phrenic nerve, cervical plexus. These codes were being reported most commonly by family physicians or primary care physicians is how it was coded, which I really do not think they're doing these at the primary care level as in-office procedures. So again, there was education from those societies, and ultimately the decision was made by multiple societies just to delete these codes. Although these codes are occasionally, certainly the cervical plexus is one that is still performed, but it was just being reported inappropriately. I mentioned the intercostal nerve code changes with shifting from multiple regional blocks to each additional level. There were new codes 3 years ago, trigger point dry needling. Again, I think that's more commonly used by non-physicians. And then the somatic nerve injection codes, and I'll touch on these briefly here for the nerves innervating the sacroiliac joint and the genicular joint. And then we have the radio frequency ablation, the destruction by neurolytic agent codes for the same. So genicular nerve block and RFA, again, this is the 3rd year with these, so you're probably all familiar, but you're only reporting once per treatment. So you're not reporting the blocks or the RFA 3 times for each of the subsequent nerves, but just once for the entire treatment. And it must be a minimum of 3 nerves. So typically the superior lateral, superior medial, and inferior medial. If there's anatomic or surgical reason not to do one, then you'd want to do the reduced service modifier, the modifier 52. And imaging guidance is included with this. So again, the schematics on the left and middle show 3 needles. The one on the far right is just 2 needles. So that you would use the reduced service modifier there. Sacroiliac joint nerve block. So this is really targeting the sacral lateral branch nerves that weren't previously described, and then the radio frequency ablation of those nerves. Again, this is one code regardless of the number of injections or burns that you do. This also includes if you do the L5 dorsal ramus, which I do, and most people will do for the SI joint denervation, that is included with this code. So it would not be separately coded with a facet joint code. So yeah, changes for this year. Imaging guidance continues to be inclusive to the Tappan rectus sheath, the paravertebral, and is now part of the axillary nerve block, the brachial plexus, single shot or catheter, femoral and sciatic single shot or catheter. The bilateral modifier changed 2 years ago to only use for the primary level, and continue to code per facet joint and not per nerve for the facet joint blocks in RFA. I will end my screen share.
Thank you, Dr. Forenkamp. As a reminder, at the bottom of the screen, you'll notice the Q&A icon. Click here to submit questions to our panelists, and when finished, click send. We will try to respond to as many as possible within our time constraints. And let's see. Go to the first. So looks like Dr. Mainkar had a question. If a PCP refers a patient for me for radiculopathy and I agree with the diagnosis, can I consider that an undiagnosed new problem, as it is my first time seeing the patient? And then what qualifies as a chronic illness with exacerbation or progression? I've read that any condition that is not at goal meets this criteria. Is that correct? And if I personally look at the patient's MRI at multiple clinic visits, if I'm doing a second or third procedure on them, can I assign them as an independent interpreter? Does anybody want to take a crack at that? I will say that
Where are the questions?
if you type or at the bottom of the screen, if you scroll, you'll see a Q&A button, and if you pop that up, it'll I guess produce it. I will say, from my standpoint, I'm at an academic center, so I do have a billing team that that helps me with this. So I don't know 100%. I've not come across those. So I don't want to respond because I'm not 100% sure. But if anybody else does. And while we're thinking about that, it looks like Dr. Adler, ordering of which, if any, pain procedures constitute moderate risk per the new E&M guidelines, so that you can bill 99214. If you meet other criteria for 99214, for example, is an ESI and a diabetic or anticoagulation or on anticoagulation considered moderate risk, or as opposed to a healthy person? What about an SAS trial or celiac plexus block? And again, I'd have to say the same thing. It's a kind of a problem of luxury that I don't have to get this deep into it. But
Yeah, and I think we can kind of lump the responses back into one. There's so many factors with it in those criteria, which, covering all fields of medicine, are intentionally vague. So I think you want to be able to justify what you're putting down, and make sure you're certainly not stretching every category to criteria. In general, the level 4 codes, the threshold's pretty low, and that is by far the most commonly coded across all specialties as a level 4 code. When these new codes were created, CMS wanted the codes to be reduced from the 5 codes down to 3, and they reduced them to 4. I'm very, as we've seen the E&M reimbursement go up, or at least the WorkVet RVU go up, I'm very concerned that we're going to see a drastic cut. Whereas if level 4 is the new normal, I think that we're probably looking at some changes there. But yeah, I would just say in general, look across all the different criteria. There's several. The level 4 threshold is pretty low, but just make sure you can justify, ideally within your documentation. But if you do get audited, any justification you have will have to be expressed in the documentation that you do have in the patient note.
Yeah, I mean, I would just piggyback off of that as well, that you can look up the E&M guidelines yourself, and they're kind of subject to interpretation, kind of not. Just, you don't want to be blatantly overcoding or even undercoding. You kind of want to be in that middle of that sweet spot. If you occasionally get one off wrong, that's probably not a big deal. But you just don't want to make a habit of continuously overcoding or undercoding. So you have access to the guidelines yourself. I think it's more patient by patient specific. I don't think that there's enough detail in the question, where I would say 100% this or 100% that. I think, just follow the guidelines. And if you feel like it meets a 99214 based on, the risk and the complexity of the medical management, then bill it as such. And if you feel like, you can also do a time component too. So if you spend a lot of time with the patient, you can bill the amount of time. So you have access to those guidelines just like anyone else. They're intentionally not specific to the specialty. So it's not like the E&M guidelines are specific to pain management or a certain specialty. They do occasionally give examples, but they're not going to be able to cover every single possible scenario. So just use your best judgment and document so that you can justify that at a certain level.
Thank you, Dr. Lynch. Looks at the next question. Does the physician's initial evaluation apply to the inpatients as well? Anybody want to take that?
All right. Are you referring to incident 2?
Dr. Nada, if you are able to, do you want to respond to that? Or she might not be listening, or he.
Which question are you referring to again?
It's Iman Nada at 7:42 p.m. But if they're not there, I think we should probably just next one if they can't respond. How do you recommend building?
I got it. I'm sorry, I was looking at the wrong area. Okay, so if you're referring to incident 2, it does not. It only covers outpatient clinic settings. Inpatients do not qualify. So that was on the presentation. Does not qualify if it's at the hospital or a skilled nursing facility, for example. Only specific non-institutional settings, basically outpatient.
Next question by Alexander Benaz. How do you recommend billing erector spinae plane blocks?
So the other unlisted procedure code 64999. This is something ASA and ASRA are actually actively looking at in terms of potentially looking at some coding solutions. But at the current time, 64999, the other unlisted code, is most appropriate, which with that unlisted code, payment is highly variable. And so that would be a reason for moving forward with that code change application.
Thank you. Next question, Colby Beal. I missed the new SI joint RFA coding changes. Can someone clarify?
Yeah, so these were became active in 2020. So they were introduced in 2018, I believe. So it's a new single code 64451, and how it's phrased is injection, nerve supplying the sacroiliac joint with image guidance, i.e. fluoroscopy or CT, which is how it appears for others. So that would be for the sacrolateral branch blocks. It's a single code that's inclusive of whether you do just the L5 dorsal ramus and S1 and S2, or if you also include S3 and maybe even S4, people are still doing that. So that's a single code, 64451. And then there's a separate code, the 64625, which is radio frequency ablation, nerves innervating the sacroiliac joint with image guidance, again, fluoroscopy or CT, which again, single code for the regardless of whether you do 3 levels or 4 levels, if you do 8 burns in the traditional cooled RF fashion. But yeah, it's a single code to describe the entire procedure, including image guidance.
Okay. And looks like Alexandra Adler, I cannot find an amount that Medicare reimburses for 64999 on the CMS website. Is this generally reimbursed?
Stephanie, is that one that you would be comfortable answering? You might have a better sense than us. I know it's mixed.
Well, like, so when you bill an unlisted code, as a standard rule, on the 1500 form, you need, most billing systems have a drop down that you can put the specific descriptor. We usually push those claims to paper, and then we know we need to submit with medical records for payer review. You obviously have to pick a price that you want to charge as a standard, and knowing that the payer is going to in turn review and reimbursement at the unlisted code, and depending on your intermediary and who the payer is. So it's typically not on a fee schedule because it is considered unlisted and specific to intermediary review. And I don't feel comfortable to say what we've gotten reimbursed, but unlisted codes are just, you know, to me, they're almost like I don't want to say experimental code, but they're a code that the payers have a little different discretion because they're not on the fee schedules, and they require you to do different things for review for reimbursement. We try to price them, you know, at a very, what we consider reasonable to cover our cost plus, knowing that, you know, from there, they're going to review it. So it's, you know, unlisted is not ideal. It's great when they give you a CPT code and you know what the standard fee schedules are by payer.
Thank you, Ms. Young. That looks like the end of our questions. See, on behalf of ASRA Pain Medicine and the APPD, I would like to thank you for your participation in today's event. The next ASRA Pain Medicine APPD Hot Topic webinar will take place on May 2nd and will focus on lumbar spinal stenosis, exam, diagnosis, and minimally invasive approaches, specifically mild vertiflex and endoscopic decompression. We hope to see you then, and please have a pleasant evening.